Today is going to be Cindy Duke from the Department of Obstetrics and Gynecology. We'll talk about an important side effect of cancer treatment, namely infertility, and what can be done to help prevent that.
Okay, thank you, and thanks everyone for your attention in advance. Just going to get set up here. Okay, so I'm Cindy Duke, and I've embarked on this project with Dr. Paul, who's my faculty mentor sitting here. Today, we'll hope to, first, I have no disclosures. Dr. Paul is a consultant for Merck, but that actually has no direct relation of what we'll be talking about today. So today we'll cover, first we'll just review the relevance for discussing fertility preservation in our patients, the national burden as it relates to the disease, the feasibility and options as they relate to fertility preservation and what's here at Yale, status of the fertility preservation utilization here at Yale, with some reflection on barriers to fertility preservation and some emphasis on barriers that we have identified here. We'll then end and cap it off with a review of some initiatives that we have embarked on to improve fertility preservation awareness amongst our community of physicians and patients, as well as really just ending it reviewing a big plan that we hope to roll out, which is the implementation of an EPIC-based alert system to further facilitate our fertility preservation goals and counseling here at the hospital. So, as is well known to everyone here and as mentioned in our prior presentation, there are approximately 1.7 million new cases of cancers diagnosed in the United States in 2013. Of those, 10% of patients, that is to say 70,000 patients, were age 45 or younger. This slide is highlighting the fact that we've gotten so good at treating cancer over the past 3 to 4 decades that survival for a lot of the cancers that are common in our reproductive age patients is actually ranging somewhere around 80% to 90%, with 90% for breast cancer, and with localized breast cancer as high as 99%. The panel on the left, or your right, is highlighting that even in childhood cancer, survival, which was somewhere around 50% or less 30, 40 years ago, is now hovering in the 80% range. Once again, underscoring that a huge swath of our patients that we are treating are having enhanced longevity. With their enhanced longevity, they're concerned about quality of life, which also includes procreative functioning and ways to afford that. So what is the bearing here? Well, as you know, in both in male and female patients, these drugs that are so effective at treating malignancy are also quite effective at affecting any cell that actually is replicating. In terms of men, they also have similar effects, but the benefit for male patients is that they have a renewal source of gametes. However, in women, as you probably remember from reproductive biology, a woman is born with a finite number of oocytes or eggs. So at any point in her lifetime, her number of eggs that she has going is actually dwindling naturally. On top of that, there are different detriments that can then accelerate that process, one of them being the toxic therapies that we use to achieve our life-saving goals. The panel on your right is highlighting what we also know, which is that at any given point in a woman's reproductive cycle, although there's one egg that's destined to ovulate, it's actually a pool of eggs running a marathon, so to speak. And so if there's a toxic hit to the ovary at any one time, we're not just taking out the egg that's leading the race, but rather we're taking out the entire cohort of runners at that instance. So, sure, this happens, but then what are the factors that actually factor into gonadotoxicity? It's multifactorial, obviously, and there are different insults that can happen. Amongst our therapies, we use chemotherapy, radiation, surgery, combinations thereof. Taken together, those have varying effects on the ovaries or the spermatocytes. In addition, there are a number of factors that are more important in relation to these. So that relates to the age of the patient at the time of diagnosis and treatment, the selection for treatment therapy, is it a combination of these? Additionally, how much, so the duration of therapy. And on the right, thinking of chemotherapeutic drugs, which we use as a huge part of our armamentarium for treating, it's good to remember that chemotherapeutic drugs are not equal in terms of their toxic effects. As you can see here, alkylating agents are actually by and far the standouts in terms of toxicity, with cyclophosphamide and procarbazine sort of heading that lead. So, okay, sure, there's a burden of disease and these drugs are toxic, but does it really matter? Do the patients care, or are they simply happy to have survived cancer? Well, one study from the Cleveland Clinic in a survey of 300 survivors of cancers aimed to answer that very question. And what they showed was that 76% of the respondents, of which there were 283, actually said that they would desire to have children in the future. 60% felt like they were healthy enough to bear children, which is a credit, again, to our successful therapies that they feel this way. However, only 25% of them actually were counseled on fertility preservation by their specialists, and only 6% actually had undergone fertility preservation by the end of that whole counseling process. And moreover, it's good to know that our committees and our governing committees actually agree with us. So the guideline and recommendation going forward is that we should be offering fertility preservation counseling in the least to every patient of reproductive age, and going on to refer them for fertility preservation options in those who are interested. It's also important to know that this is actually one of the things that has been highlighted as a potential medical legal topic in years to come, but of course we're talking about it ahead of that. Now, what options are available? There are a myriad of options available to a patient who's interested in fertility preservation. Truth be told, they're not equal. They range from simple things such as ovarian suppression with medications such as GNH analogs, primary of which that we use here at Yale is GNH agonist, or Depolupron. It's actually the most utilized method here at Yale. However, it's the least studied in terms of fertility. I'll talk a little bit more about it in the next slide, but I just want you to keep that in mind as I talk about the others. The gold standard actually for fertility preservation is embryo cryopreservation, which involves the harvesting of eggs from a female patient, using a donor sperm or partner sperm, fertilizing those eggs, and then freezing the embryos for use later after the patient has recovered from her disease and therapy. Short of having sperm, if the patient is either an adolescent or does not have a partner available donor sperm, we can actually store those oocytes and then fertilize them later, with fertilization success ranging between 25 to 40% in thawed oocytes. And then there are a host of other options that are more specific depending on what the patient is afflicted with. So going back to GNH analogs, actually before we go to GNH analogs, this is an algorithm outlining sort of our mind process and our thoughts when we see a patient for fertility preservation. And the first thing as we go, remember going back to considerations, is how old is the patient, and stratifying as to whether the patient is prepubescent or postpubescent. That is, has the patient had her first menses, which is prepubescent if they have not, or if they're menstruating, postpubescent. If a patient has not entered into her menstrual cycles, meaning our young patients, anywhere from birth through 9 or 10 average, then there's not much we can do in terms of stimulating the ovaries, so the only offering at that point is to freeze ovarian cortex or whole ovary, and that is definitely available and offered here at Yale. In the postpubescent patient, then the question becomes, is there enough time to move on to stimulation? So certainly this is something that we do in conjunction with the patient's working team for treating their malignancy, recognizing that the patient's prognosis comes first. However, if there is enough time after discussion, we can then do different stimulation protocols that also include utilization of drugs such as aromatase inhibitors or letrozole to maintain low estrogen levels, such as in patients with breast cancer, while stimulating oocytes, retrieving eggs, and then either cryopreservation or oocyte or embryo. In a patient there's not enough time, currently the thing that we use the most, if that is actually brought up is GNH Analog, such as Depo-Lupron. Other things that are available are in vitro maturation and tissue cryopreservation. So going back to GNH analogs, which, like I said, is actually the most utilized here at Yale, the data shows that it is very effective at salvaging ovarian reproductive function. But it's key to remember that all the studies that looked at the use of these drugs for ovarian function really looked at, as their endpoint, resumption of menses. So there's not enough data yet to actually say that these medications are good for fertility preservation. Rather, they're good for resumption of menses or reproductive function, which in itself has its benefits as we're preventing menopause and therefore the sequelae of early menopause. In terms of men, like I said, they do have a renewed cohort of gametes. However, drugs can be toxic as well. Number of things available that we offer. Sperm can be collected within 1 to 3 days, depending on the production within the patient, as well as there is available tissue cryopreservation. So we've talked about the burden, we've talked about the patient perspective, we've talked about the options available. How are we doing nationally? Well, nationally, this pyramid really sort of makes it very nicely concise. So the insult, as you can see, is the bottom of this pyramid. You have a large group of patients. Only a smaller proportion, displayed in blue, move on to receive fertility preservation counseling. And of that, as evidenced by that study done by the Cleveland Clinic, only an even smaller number of patients go on to utilize fertility preservation. So the question is, what are barriers to utilization of fertility preservation? So nationally, barriers that have been identified include lack of awareness amongst physicians and patients alike. Another huge factor is provider bias, and a lot of these biases are actually well-meaning. So usually there are some excuses such as, well, the patient has completed children. It's really an assumption that the patient has completed having their children. The patient cannot afford it. Again, this is based on what information. Sometimes it's simply more so what we assume the patient's resources are rather than a true discussion. And honestly, they do not really take into account many times patient autonomy, which is they should actually have the choice in the matter. The other is there's just not enough time. And truth be told, that is a continued issue. We recognize that malignancy is a reality, and if that is the case, then we work around. Other strategies are available. Other biases that come up are the patient is already stressed out. I don't want to make things worse. As you can see, 76% of our patients actually would like to hear about fertility preservation and would like to have children in the future. So it's worth bringing it up considering they're already stressed. True. And the last is the continued belief amongst providers, including our own providers here at Yale, that there aren't available services for their patients. The truth is all of the options that I've outlined and the ones that we didn't quite touch on are available to everyone here at Yale. Hold on. Doesn't want to move forward. Okay, continuing on. So we've actually, as part of understanding the barriers that we saw nationally, we wanted to see what were the barriers specific to us here at Yale. And so the first thing that we've been doing is under the tutelage of Dr. Paul, Dr. Monica Pasternak, one of our residents, has embarked on this survey-based awareness campaign to work with our providers here across different disciplines at the hospital. So one of the questions in the survey, and the way the survey works is there's a pre-test, a 1-hour review of fertility preservation options and strategies, followed by a post-test assessing both pre and post for awareness. So one question was, how often do you, the provider, initiate fertility preservation discussions with your female cancer or rheumatologic patients? Pre-test, as you can see, there are only about 31% of patients, with only 4% always asking fertility preservation issues. Post-test, with this awareness campaign, there was a significant increase to about 93% post-test. The following question was, how often does or will, so assessing intent, preservation of future fertility help guide your management for eligible patients? Pre-test, only 38% considered it sometimes, with none always. Post-test, there were 94% who would actually consider it, 33% now considering to do it always. So a significant improvement of awareness and intent. We then asked questions related to barriers to fertility preservation. So what barriers may prevent you from initiating fertility preservation discussions with your patients here at Yale? First was lack of access to specialists. Pre-test, it was 15%. Admittedly, that did not change much. It was 12% post-test, suggesting that we need to do some more talking to understanding and helping community know who a specialist for fertility preservation is. Following was, I do not know whom to refer to, so 38% to 0%, so that was a significant improvement. Other highlights were one question such as, I am part of a referral service and defer discussion to primary team. I think particularly in this audience, this is important to remember. So it means that there's a significant number of us who actually feel like, well, I'm the specialist, so that should have already been covered with either the diagnosing provider or the primary team, whomever that may be. The truth is, if you haven't seen it documented or the patient does not seem to have an understanding of it, it may be worthwhile reviewing it at least once, just touch upon it to see if indeed it has been addressed. Okay. So just looking at the burden here at Yale, so we talked about the national burden. Here at Yale, there were close to 3,000 patients diagnosed between the ages of 0, so birth, and 49 years with malignancy in the past 3 years. As you can see across the years, 2011, 2012, 2013, the numbers of patients who are newly diagnosed and treated with cancer in those age groups remain fairly consistent. So we have this many patients per year. Looking at the 30 to 39 age group, which is the purple column in each section for males or females, you see that the numbers don't change much and they're hovering well over 125, closer to 150 annually in the past 3 years. So the burden is here, we have patients. So how are we doing? If in fact we have patients, and this patient group actually, so this is 10% of the patients who are diagnosed at Yale in the last 3 years, and of that 10%, 92% were between the ages of 10 and 39 years old. So how are we doing? Well, what we did was a quick query of the pharmacy orders, looking at the dispensation for cyclophosphamide, which is one of the leading toxic chemotherapeutic agents, asking how many patients who received that chemotherapy actually have documentation of fertility preservation. So recognize it's not finger pointing, we're just looking to see if it's been documented. There were 54 patients ranging between age 12 and 45. There were 199 orders placed suggesting patients receiving multiple doses of cyclophosphamide, and of those it was across 13 different subspecialties, so a nice variety of groups. However, only 5 patients received a consult. That is 9% of the patients. So it is consistent with the national data that we've seen. However, speaking as the fellow who did all those consults, I can guarantee you it's clearly not enough, right? Yes, question.
Did you track those via like an ordering system, or did you go into the progress note?
We actually went in through the ordering system first and then looked for how many had consults or who had a note written. Just,
You did look at the
yeah.
note to see.
But this was only for cyclophosphamide and only for one period, 1 year. Correct. So if we're thinking about a fertility preservation program, the question is, how do you really validate success? Is success the number of consults, the number of documented counseling? Well, there are actually there are nice rubrics that have been set up out there to help guide us. And so in terms of practical considerations, there are steps 1 through 6. And truth be told, we are actually at step 6, which is ongoing program assessment. So we have gone on to set up a fertility preservation program. There is ongoing discussion amongst services and delivering providers. However, there are gaps that have been identified. So for example, although we are at step 6, key to step 1 was providing staff with empirically supported continuing education on fertility preservation. We've only now begun doing that. So clearly that's one gap. Another gap was in step 3, which is to develop real-time referral system, including transfer of health information. One of the benefits of having an electronic medical record system is quick and easy access to all providers to the same information. So that is one benefit. However, the referral system, as we've recognized from talking to different services, is not only are people not aware that fertility preservation options are widely available at Yale, but the second is, I don't know how to reach you. So one would be maybe using that electronic medical record to facilitate that referral service, or at least a curbside for counseling. The second is utilizing navigators and survivor clinics for outreach to just raise awareness. And again, this is not a campaign for getting fertility preservation, but rather at least for counseling. And last is establishing a system to assess. So the last couple slides is actually just to review those gaps, to sort of encourage you and to enlist you in our call for action as we try to improve at least the delivery of fertility preservation counseling across the healthcare system. So we have, as a division, embarked on our strategic approach to improving patient autonomy and patient access to fertility preservation, recognizing that the first step is actually getting our providers on board. So this is afforded through our HIC-approved survey study that we've been doing. It's an ongoing project, going to different divisions, again, for 1 hour, reviewing all the options available, the biology behind it, and then answering questions as they relate to your practice and specialty. As I showed you with the hospital query, there are 13 different services that order varying types of chemotherapeutic drugs. Therefore, it needs to be a catch-all if we can. And we also have our experts who go on to answer further questions and delve into things that are more practical if you were so interested. The second is going back to that use of the electronic medical record. Now, as the fellow doing the consults last year, I would say one of the things that was very concerning was if indeed a fertility preservation consult was called, particularly for a patient in the hospital, it was usually only called within 48 hours of induction of chemotherapy. Review of the patient's charts reflect that the majority of the patients had been in hospital anywhere between 4 days to 7 days before that consult was initiated. Moreover, there was already discussion of the diagnosis or an actual diagnosis entered somewhere within 4 to 6 days prior to the calling of the consult. So it suggested that there was somehow maybe, with all the busy things that we have to do, that was not remembered until very late in the game, which then sort of limits what options are available. For example, use of Depo-Lupron, which again, as I said, is the most common option that is utilized at the hospital, actually requires somewhere between 5 to 7 days prior to induction of chemotherapy to actually have the desired effect. So given that, after talking with a number of providers here at the hospital, meeting with the pharmacy services, meeting with Dr. Adelson and colleagues of the quality division here at Smilo Cancer Center, we have decided the best might be to actually implement within EPIC a best practice advisory system, much like you see when you're ordering a renotoxic drug, etc., where a quick reminder comes up to say you are ordering a known renotoxic drug, have you checked the creatinine or have you checked, etc. This advisory or alert will fire when specific diagnoses are entered into the problem list, hoping to catch patients earlier, with simply a reminder, did you offer fertility preservation counseling? That's all it's going to ask, and it's a checkbox. And then it will go on to ask, would you like to order a fertility preservation counseling session if you don't feel comfortable, or consult? It will also fire again when known gonadotoxic drugs are ordered. So it's once again just a reminder, because yes, it's a busy service. For many of us, we have varying levels of trainees on our services, as well as there are lots of priorities that may not be the first one. It's really just meant to prevent patients falling through the cracks, basically. The other benefit to this would be that we can then go back and assess ourselves. Again, like number 6 in that paradigm, assess to see whether or not we're actually meeting our benchmarks as to a successful and effective fertility preservation program, primary of which is counseling. Sorry, did you have a question? Oh, no, okay. And then last is also, again, talking about implementing the EPIC consult system so that you can reach the fertility preservation team at the Yale Center should you need to talk with them, either for inpatient or outpatient, or just for a curbside for counseling. And the last is there are a number of services available to facilitate patients getting fertility preservation. Certainly, there are a number of cost-cutting things that we do at the clinic to facilitate patients. But one thing that is evident nationally, and again, we alluded to, and even provider bias, is the assumption of cost. And certainly one of the things that we probably could do, and this is more of talking about a national campaign, not saying you need to do it, but maybe we should start talking to our representatives about really the impact of these medications that we use on fertility and future reproductive considerations, and perhaps making it such that our programs for insurance coverage will cover this. It's certainly covered in other countries, but not one of the things that's regularly available here. And that will conclude our talk. I've actually made available some just ways to reach us, and also additionally just a quick paradigm for how you consider whether or not a patient might be eligible for fertility preservation and what you can do to start. Thanks for your attention.